Welcome to SkinSync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hello, everyone. Welcome back to the SkinSync podcast. This is Buchi Neita, and I'm pleased again to introduce you to my co-host for the day, Jenny Laminack. She is a fellow Elevate board member, and she's a colleague here in the Atlanta area. So, Jenny, welcome back.
Thank you so much for having me again, Buchi. I'm excited to be here.
So I'm so excited to kind of talk about this topic today. I think it impacts us literally every day in clinic and most of our patient encounters, but we want to talk about the psychosocial impact of skin disease. We recognize that in derm that some of the chronic diseases that we're dealing with, whether they're visible or not, have a major impact on patient self-esteem, their confidence. And our goal is really to help better recognize some of these psychosocial burdens and be able to offer patients support in managing them. So before we get started, Jenny, can you share with me, and I know this is a open time, be vulnerable with me here. That's what we do on the SkinSync podcast.
Uh-oh, okay.
If you could just share a time with me in your history, in your life, whether it's childhood or even now, where you've had a skin condition that's left you feeling embarrassed, or maybe you've had to cancel plans because of it, or maybe just avoided looking in the mirror because it was uncomfortable for you. But is there anything that you've dealt with where you can kind of identify with patients?
Absolutely. I think dealing with acne, of course, like in the formative years and the teenage years, is one thing. When, of course, like you're feeling self-conscious when you're at school and things like that. But even now, like I hate to admit, when I'm getting even like a pimple or two, it really only takes one to make me feel self-conscious when I'm going to see patients and they're seeing me for their skin issues and I'm dealing with these blemishes. What are you going to do? How about you, Buchi? Have you anything like that?
Oh, yes, the same. So, and Dr. Julie Harper talks about this a lot, where she will ask the question before she starts her lecture, how many pimples does it take to ruin your day? And everyone basically raises their hand and says one. That's it. And
That's the
yeah,
answer.
and that's it. So even in my adult life, I do all the skincare and do all the things. But yes, I still have acne. And for me, the worst part is not even just the pimple, but it's the hyperpigmentation that I know I'm going to have. It's inevitable for my skin type. And I'm left with that usually for months trying to battle it. So very frustrating. But another thing that was actually more kind of heartbreaking for me, this was maybe a decade or so ago. I was dealing with this chronic rash. It was on the back of my hands, it was on my elbows and my knees. And mind you, I was a young single woman in Atlanta just trying to, enjoy being in this big city. But it was this
Sure.
this lichenoid type of eruption. I and still don't know to this day exactly what it was, but it was very scaly. It was very hypopigmented. It was irritating and itchy. I would kind of pick at it. I'd tried every topical you can possibly imagine. I wasn't getting success. I actually went to go see a derm in the metro Atlanta area. I actually saw a couple of derms, had multiple biopsies, and just still couldn't get to the bottom of the diagnosis. But it was visible. It was visible, and this is a time again where I'm outside every weekend. I'm out and about. But I remember I had a friend of mine, a really good friend, and again, she meant nothing by this, but there was a time when my rash was really flaring, and I had reached out to either give her something or to touch her, and she physically recoiled at my hands. And it was so heartbreaking, and I had to just kinda control my emotions at that moment and just pause, and again, it wasn't her fault, it's just like an automatic reaction, but I remember to this day how painful that felt, to have someone recoil at you, and again, it wasn't
For
contagious, it was nothing
sure.
they could catch, but it was just really, really, just very sad to experience that, and I remember it again, it's been over a decade, and I still remember it to this day. Thankfully, that rash disappeared. I got pregnant with my first child years after, and I've never seen the rash again, so he cured me, I guess, but yeah, so just again,
That's
we've
nice.
all had these experiences where we're dealing with, these skin conditions. I think it's important to always put yourself in that patient's shoes, put yourself back in that moment where you felt that embarrassment or that anxiety about what you're dealing with, and just try to use that to really identify and connect with the patient. But what are some of the
Sure.
common things that you run into in clinic, Jenny? What are some of the conditions that you're treating typically that seem to have some of the highest psychosocial burdens?
Well, speaking of acne, again, one I can relate to myself, I think a big part of acne is that it does develop in your adolescence, and that's these years where you're developing your personality, developing your self-esteem. So it really, I think early on, just like you said, you could remember your friend's reaction, that's something that I think really sticks with us. So it really these long-lasting consequences on self-esteem for these kids.
Absolutely.
Um, and different do you ever see, like, in clinic, your, like, or even just any patient really with acne, like, how do you feel like you end up identifying, like, if they're dealing with these type of, like, psychosocial issues?
So sometimes I'll just ask, at least very vaguely, I'll ask them, on a scale of 0 to 10, how much is your acne bothering you? 0 meaning that it doesn't bother
Uh.
me at all. I don't know why I'm here today. My mom dragged me here. Or 10 being this is the worst thing I could possibly be dealing with. And I feel like the kids are pretty honest with me about it. And
Mhm.
sometimes if they're not, if you're really having a hard time kind of building that relationship or that rapport, just kind of paying attention to their demeanor, right? I mean, teenagers sometimes are not always the most social, and I think there's a little that awkwardness that comes with that age group. But I think paying attention, a lot of my young males, they'll wear bangs, not just for the style, but they'll wear the bangs to actually cover up
Ex
their acne. I'm sure you've seen a ton of that. They'll oftentimes they're
Yeah.
not looking directly at you; they're looking down. So you can pick up on some body language that'll tell you that these people are not having the confidence that they would like to have. And then, of course, treating with isotretinoin, I'm sure you see this all the time, but, like,
Yes.
that flower that just kinda blossoms and opens up, or you see this teenager that was really shy and withdrawn now being
Mhm.
open and expressive and talkative. That's probably one of the best feelings in dermatology is treating that patient.
I agree. That's one of the best feelings, and just seeing them, month to month because inevitably you have to, but you're sort of building this relationship and seeing their self-esteem really flourish.
Right. And one thing I do wanna mention, it's not just the acne itself, right? It's some of the sequelae that come with acne. It's the hyperpigmentation, it's the scarring. And so while you may have a patient that does not have severe acne, per inflammatory papules, pustules, and comedones, they may have significant scarring and hyperpigmentation. I think that's still worth addressing and obviously worth treating if necessary. So don't forget, again, some of the after effects that come from having severe acne. So
Right, that's such a good point,
yeah.
and that all sorry, that's such a good point, and often even lasts longer than the acne itself,
Exactly,
right? So
exactly. So another condition that we tend to see quite a bit of in clinic, of course, is psoriasis. And I think for over the last decade or so that we've been in practice, we're learning so much more about the disease. We've got so many more treatment options, but we know that there's much higher rates of depression and anxiety in this population, higher risk of suicidal ideation in this population. Substance abuse is much higher, particularly alcohol and smoking. And one study that I read that I thought was really interesting was that patients with psoriasis have not only reduced self esteem, but increased anger, which you can imagine, like, right? It's frustrating. Why were you
Right.
burdened with this condition, but increased anger, which I don't think I've ever heard of for another condition before.
Yeah, but you could see that frustration, when patients come to see us, and some that have really come early on when the condition just develops, but those that have been dealing with it for years and years, like, when you said anger levels, like, it's understandable kind of from where they're coming from.
Right. And one thing I want to point out when it comes to psoriasis is that the severity of the disease clinically doesn't always correlate with how the patient's feeling about their condition, right? So we know that you might have
Mhm,
50% BSA, and you've got patients that are pretty okay with that. Like they're not super bothered by it because it's not itchy.
mhm,
Maybe they can cover it up. But then you'll have patients who have maybe 1 or 2% BSA, but it's their scalp or it's their genitals or their palms where it has
mhm.
much more of an impact on their day to day life. So remember that again, it's not always BSA, it's not always what you're seeing clinically. So make sure you're asking the questions to kind of figure out why they're bothered by it or what still bothers them.
Absolutely.
Right. So what else are you seeing, Jenny? Any other conditions that really stand out to you?
One I think eczema is a really common one, or eczema or atopic dermatitis, and I find that it can be really frustrating for patients because they don't know when they're going to flare. They're sort of living this life where they're just sort of waiting for their next flare in a lot of scenarios. Also has a really big impact on sleep, and we know that sleep has a huge impact on so many other aspects of our lives, and particularly our health. So up to 80% of kids kids and 90% of adults experience sleep disturbance just due to this itching. So I think without a doubt, huge impact there.
Yeah, and Dr. Tina Butani did a great podcast with us some episodes back, so go back and listen, where she
Mm.
talked all about sleep and when it comes to sleep and dermatology. But oftentimes, when you're dealing with poor sleep or deficient sleep, it actually can worsen the impact of the disease, in general. Not to mention some of the serious medical concerns, cardiovascular disease, the mental health disorders that can be worsened by it. So we know sleep is critical when it comes to these
Yeah, it's
patients. Mhm,
such a vicious cycle when you're
absolutely.
when you're not sleeping.
So, moving on to a condition that's been getting a lot of love lately, which is vitiligo, and I'm so happy to be seeing more and hearing more about it. We have one approved therapy currently, we've got hopefully more to come. But obviously, this one has a very obvious stigma associated with it because oftentimes it's very visible, right? And culturally, there are some cultures out there where I think it's becoming more normalized in the US, but in places outside of the US, in India, oftentimes it's been associated with less advancement in your career. You're less likely to marry if you have this condition. In some Arab countries, it's been shown to be associated with like essentially being cursed, or it's people are considering it's your fate or destiny to have this condition. And in Nigeria, it's actually been linked with leprosy. It can have similar features when it comes to hypopigmentation, along with leprosy. And so, obviously, people who have leprosy are typically isolated, and that can happen with vitiligo patients as well. So, it's so much more than again just this condition or cosmetic disorder, like people would like to believe. It has a major impact on patients. Is that something you've encountered as well?
Wow. Maybe not to necessarily the degree that you're saying in other places where it's impacting the full outcome of their lives. But without doubt, the patients, which of course we know vitiligo likes to start around the eyes, and this kind of mass distribution around the mouth. So in really visible areas. So I think, yeah, without doubt, having a pretty big impact in such a visible area.
Yeah, and those were some of the things that actually were associated with the people that had the highest burden on their quality of life. If you had greater than
Mhm.
5% BSA, if you had a darker skin tone, so Fitzpatrick's 4 to 6 usually had a higher
Yeah.
impact, and again, facial involvement or hand involvement, right? Because you're trying to avoid shaking hands, or you've gotta consider, what you can and can't wear, or wearing a cosmetics to cover it up. It can be a really major
Mhm.
burden. And then one study I found really interesting, that was a 2024 study that showed that there's this bidirectional positive causal relationship with vitiligo, meaning that patients who have moderate to severe anxiety and depression, it can actually significantly influence the efficacy of their vitiligo treatment. So people who have severe depression and anxiety tend to have less effective therapies. And I'm not really sure as to why that is, if it's they're less likely to be compliant with their therapy, if perhaps the anxiety and depression is driving more inflammation. I'm not really sure the reason, but I thought that was really fascinating and really very sad to hear.
Yeah, maybe a mix of both. That
Right.
is that is very interesting to hear and to know.
So, what else are you seeing? Alopecia areata, I'm sure, again, another condition getting a lot of love lately. What's been your
Mhm.
experience with that in clinic?
With my alopecia areata patients, I feel like I'm fortunate not to see patients in the clinic dealing with mass amounts of hair loss, like over 50% hair loss, which is unfortunately the medications, these JAK inhibitors that are out and approved, that's really what the insurance wants the patients to have. But I find that even a small amount of hair loss, if it's in a place that's difficult to cover, has such a big impact on the patient's self esteem. So it really doesn't matter the amount that they have. It's more about just that it's there, and in particularly like the area that it's there. What are you seeing in clinic with your alopecia areata patients,
Same
Buchi?
thing. I see quite a bit of hair loss, and not just alopecia areata, but I mean hair loss across the board. But there's such a connection with your personal identity. I mean, as someone who, as a Black woman who goes through from one month to the next, my hairstyles are varying. But just to not have that option would be really distressing to me. And yes, you can wear wigs and you can camouflage it and cover it up. But I think a lot of women want their self image relies on being able to wear their hair in a healthy, natural state. So I think that's a big issue. And with those
Sure.
patients that do have more involvement, who do have more severe alopecia areata, of course, there's this relationship with it being, chemotherapy. Like, are you sick or what's going on with you? You must be going through cancer therapy. So again, people automatically look at you and assume that there's some major issue, especially if there's loss of brows and lashes as well. So again, this is something, again, major
Right.
impact on patients' quality of life.
Right, and the people making assumptions about their health, that's something, yeah, that was a great thing that you touched on there because a lot of people don't have the awareness about what alopecia areata is or alopecia totalis, so that's a really good point.
Exactly. And there's plenty of evidence, and you guys will find that the common denominator in all these conditions is again higher rates of anxiety, depression. Every single condition we've stated so far, there's data showing that there are higher rates of these conditions in these patients. With alopecia areata specifically, there was a small study of 75 patients that showed that 66% had depression, increased rates of depression, and 73% expressed anxiety. So again, really, really distressing disorder for patients. And then last but not least is a condition that's very near and dear to my heart, which is HS. Again, getting lots of love and lots of shine in the recent years, but I think it's still one of the most devastating disorders that we treat in clinic. And as I'm sure you
I
know
agree.
with Jenny, our patients, oftentimes they're suffering in silence, right? Because it's not visible, it's not usually on their face, it's not usually in areas that other people can see. So their condition can easily go minimized. It can be very misunderstood. People don't quite understand why they're having these issues.
Right.
They've actually shown that not only are they dealing with the burden of the anxiety and stress, but there's actually a decrease in their career, right? So they're usually having more absenteeism where they're missing work more frequently. That's gonna obviously have financial implications for them. And patients with HS are often taking medical leave. They're missing, on average, about 39 days of work throughout the year, lost income, obviously, and they have a higher rate of long term disability. So, again, it's so much more than what we're seeing just clinically. It's all the after effects that come with having such a severe disease. What else are you noticing with your HS population?
Yeah, like you were saying, yeah, that it impacts so many aspects of their life. I find I have one in particular patient who I adore. I think I empathize with her because we're almost the exact same age, and her not being able to be intimate with her partner, that's such a big deal for her because you're dealing with this like drainage and this cysts in these very sensitive areas, very personal areas, and I think that can really get in someone's head and kind of cause that depression.
Absolutely. And I think you mentioned earlier with atopic dermatitis, but same with HS, there's this lack of control where you have no idea when your next flare is going to
For
come.
sure.
So you're trying to enjoy a nice vacation or a getaway or, something simple or again, an intimate moment. And all of a sudden you're dealing with a painful cyst, draining odor, discomfort. You're having to make sure that you have the right dressings available to pack your wound. So again, very distressing. You have no control. And a lot of patients it'll lead them to self-medicate. We have really good therapies now, but they're still not, 100%. So patients oftentimes will find ways to self-medicate, and unfortunately, they're not always positive. So they have higher rates of substance use, alcohol, marijuana, opioids, and unfortunately, again, higher rates of anxiety and depression. They have a 2.4 times higher risk of suicide. So again, very, very devastating disorder that we see in clinic very regularly. But I'm glad to know that there's a lot on the horizon for patients who have this condition.
It is. It's an exciting time for treatments for HS and really excited to what's gonna be coming in the next, like, year or 2.
Absolutely. So let's kind of just briefly talk about some of the objective measures that we have. So if we have a patient where we're thinking that there could be some psychosocial burden going on, what are some of the things that we can use to try to really assess that and document it clearly?
Right, so, kind of reading through different scientific papers, like different journals, one that came up multiple times, that when reading is the Rosenberg Self-Esteem Scale, and it's a pretty quick test for our patients. It's a 10-item self-report measuring, like, your global self-worth and your self-acceptance, and it's these 10 statements that are, like, basically explaining how you feel about yourself in this moment and how if you agree or disagree or somewhere in between, but asking just gonna give you guys a few, but on the whole, like, I am satisfied with myself. At times, I think I'm no good at all. Like, these are really kind of powerful statements, and I think it really makes the patient think about what their mentality is and kind of like what their mental status is, and also makes us a lot more aware of what's going on with them.
Absolutely. Another measure I think we're more familiar with in some of the clinical trials is the Dermatology Quality of Life Index, DLQI. This is widely used. I think it's actually the most widely used patient reported outcome or PRO measure in derm. And it just helps us to assess kind of how patients' day to day is. So again, it's asking questions like how itchy, sore, painful has your skin been? How embarrassed or self conscious have you been about your skin? Has it interfered with you doing normal activities like gardening or shopping? So, again, things that patients may not always share with us in that encounter, but are really, really important for us to know. I don't personally use this checklist, Jenny. I probably should. How about you? Do you use
I
any of these measures?
Bushi, I do not, and I should.
But we're
I
going to do
should use
better
these more
after
objective
today,
measures.
right?
We absolutely are,
Yes,
but of course, asking more, open-ended questions about how they're doing, how their like quality of daily life is. Of course, we're asking those, but more informally, I'm asking about their mood, if their
right.
conditions just limiting any of their activities.
Right. And then another questionnaire that's actually done quite a bit outside of dermatology as well is the patient health questionnaire. It's
Mhm.
PHQ-9. This is more assessing for anxiety and depression, and really this particularly depression, but it gives you a sense of the severity of it. So it goes from anywhere from none to severe and gives you recommendations on if you need to refer and when. But it asks questions about,
Mhm.
are you feeling down, depressed, or hopeless? Little interest and pleasure in doing things, trouble falling asleep or staying asleep. So again, probably something that we should incorporate in patients that are at high risk. So you mentioned a few ways, Jenny,
Okay.
to help recognize some of these burdens. One of them is asking
Mhm.
open-ended questions to patients. What else are you doing to try to make that assessment?
Um, Trying to now I'm going to try and use more of these screening tools.
Yes,
And honestly, I think even especially the DLQI, that would be something they could even fill out while they're waiting on us to get in the room. So it would just be information that we could have even going into the room. So I'm definitely going to be using that kind of
absolutely.
as we head back to clinic.
And I think that's something that you can use either a new patient with a condition that, or maybe they're coming in with a concern about
Mhm.
cysts or, abscesses, or a patient that's well established, but you just want to assess how they're doing in their day-to-day life. I think this is something a tool that you can use pretty much in any patient encounter. And so, what are some other things that we can do to kind of support our patients, to show that we understand, to provide tools and resources? What are some of the other things that you offer your patients, Jenny?
I think number one is listening. A lot of these patients, especially, I'm thinking about the hydrogenized Serpativa population as well. Like they've not been listened to and they've been dismissed in a lot of different cases, and that's not just for HS. There's for several skin conditions, but being able to make them feel heard and empathize with them and validate their feelings, I think, is huge.
Yeah, I think another thing is really normalizing it, right? If a patient does express, some sense of distress or lack of confidence or self-esteem, or even depression, normalizing it, letting them know that this is actually really common. And I would be surprised if you weren't having these symptoms. I think it's really important that we address, just really making sure that they understand that they're not out of the norm, that they're not exaggerating their condition, that we don't want to be dismissive of it. I think just helping them recognize that it's normal to feel this way, and we're here to try to help and address it. Are there
For
any,
sure.
resources that you use or websites that you recommend for your patients to access to learn more about their condition?
And just depending on their condition, we recommend like specific patient advocacy groups. Um, so, National Eczema Foundation, the NPF, NAAF, HS Foundation, Global Vitiligo Foundation, all really reputable resources.
And reputable, keyword keyword reputable, because obviously we know our patients are going online everywhere, pulling information and coming in oftentimes with the wrong info. So if we can just give them some guidance towards the right resources, I actually provide a handout to my HS patients that has a list of some of the best patient advocacy groups available so they can go directly to those websites. So that's something that I've actually implemented in the past year or so. But again, just
That's
giving them that
awesome.
information. And oftentimes these websites will actually guide you, that they have support groups, they have meetings, they have events where
Mhm.
patients can actually physically be active and participate and meet their peers. And I think that's a beautiful thing to have someone that understands what you're dealing with and understands your struggle. And a lot of our wonderful pharma companies and industry friends have been providing really, really great non-branded patient education, whether it comes through handouts or just online websites. Again, there's some fantastic ones out there for HS and some of the other conditions that we treat. But anything else that you're doing, Jenny, for your patients?
Those are the main things. Of course, if needed, we do psychiatric referrals, though that can be tough to get them into
Yes.
in a timely manner. So I think all those just reliable tools that we mentioned earlier just need to be using them in clinic on a regular basis.
Yeah, I think the psych referrals, it's tough sometimes, and I try to keep a list of at least a few in my community. Oftentimes, they're not accepting new patients or they have really long wait lists, but sometimes just getting them back to their primary care provider. If you have a relationship, if you have their number, if you can get them in for a quick appointment, I think it's really helpful. Do you find, Jenny, that your patients are often receptive to psychiatric referrals or psychology referrals? Do you find that they actually want this referral?
It can be a bit of a hit or miss
Right.
situation, right? Because we do want to normalize, like, their feelings and everything and don't want to make them feel as if, we're, like, putting them on someone else or saying, like, "These are abnormal feelings, like, you should go see someone about it." So, it's a very delicate balance for
Absolutely.
sure, and just knowing the right patient.
I
Mhm.
agree. I have one I'm thinking of right now where I've probably seen her for 7 years now, for her HS, and I think there's been numerous times, usually every other visit or so, I'll mention, like, "I think it would be worthwhile to just have a relationship and establish an appointment with a therapist," and she always tells me she will, and she never does, and that's okay. I'm just there to provide the
They're
information, support, refer, whatever you need from me. I just wanna make sure that she knows, and oftentimes I think she just finds relief in just talking to me. Like when we have our visits, I'm that counselor. I'm that therapist for them. You
Yeah.
just are, a sounding board, you listen, you empathize, and oftentimes that's what patients need. So even if they don't want to get the direct referral, you can be that person for them.
Sure. Yep, we wear many
We
hats, and I'm
sure
sure
do.
that you've, like, changed her life in so many amazing ways.
Absolutely. So, Jenny,
Yeah.
this was wonderful. So, thank you so much for doing this with me. I think it's, again, important for all of us in clinic just to recognize that it's beyond just what we're seeing clinically. What are the psychosocial burdens? How do we help support our patients? What questions can we be asking in clinic? Are there tools that we could be utilizing? But let's do a little bit
Mhm.
more to make sure that we're giving our patients the best and adequate support. So, thank you, Jenny, for being here.
Absolutely, thank you so much for having me.
All right. Thanks for listening, guys. Take care.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.